Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi, welcome to Melanoma Matters. My name's James Larkin.
And I'm Sapna Patel.
Okay, so today we're going to be talking a little bit about Keynote 716, but before we do that, Sapna, I'm going to ask you some quick fire questions. So, have you ever won the lottery?
Scratch off? Sure. $1 here, $2 here. I won probably $20 on a scratch off one time. But the real story about the lottery is my mom. It was I'll correct this in a fact check if I need to, 1995, probably before that, 1989 maybe. We had our last Democratic governor of the state of Texas, Ann Richards, famous grandmotherly looking woman, which was probably part of how the appeal that she was a Democrat. And she beat out Republican candidate for governor. She signed off on the first Texas lottery that had happened. We had not had a state lottery before then. My mom goes and buys a ticket, and it's a pick 6 or pick 7 or something. And she gets 4 out of the 7 numbers in that very first Texas lottery. And it gets her, I don't know, $1,000 or $2,000, something real. And my sister and I remember it because it was November, and we had a really nice Christmas that year because my mom came into a little windfall. So that's the real story. But I work with a lot of nurse practitioners in Houston whose, aunts and family members have on the slot machines won $100,000, $200,000. And I was just at an investigator meeting with a colleague, I wonder if I should say her name, in Las Vegas. She had never played the slot machine before. We put her money in. She hit the button. She won $1,100 on her very first ever spin on the slot machine. So, listen, luck abounds.
Yeah, I'm just trying to work out what the moral of the story might be, but maybe we can't dwell on that too much now. So, okay, so let's talk about Keynote 716. I guess the context is we talked quite a lot already about adjuvant treatment, at least checkpoint inhibitor treatment for stage 3 melanoma. So the question is, what about stage 2 melanoma? So over to you.
Keynote 716. So we started moving these things earlier and earlier in the regimen. I mean, eventually, gosh, would we ever use therapy for stage 1? I hope not. But for stage 2, there is the whole rationale is that there are some stage 2s that still have a real risk of recurrence that are approaching the risk of stage 3. So for example, 2Bs approach the risk of 3A, 3B for risk of melanoma recurrence in the first 5 years. 2C does worse than 3A and 3B for risk of melanoma recurrence. So there probably is some risk reduction that's still needed for that stage 2 population. So Keynote 716 was a randomized phase 3 trial, pembrolizumab versus placebo for completely resected stage 2B and 2C. And what they mean by 2B and 2C completely resected is that lymph nodes were all removed in these patients. So sentinel lymph nodes were removed and histopathologically negative, which is really important, I think, as you talk to surgeons, and maybe we should even talk to a surgeon on one of these podcasts. What is their feeling around the omission of sentinel lymph nodes and the estimation of, the microscopic lymph nodes we're leaving behind? I've heard it range anywhere from, 10 to 40% in this clinical stage 2. So for the purpose of 716, they were histopathologically stage 2B and 2C. So sentinel lymph nodes were removed and known to be negative, randomized to pembro or placebo. There is a crossover in 716, but for many reasons, and for reasons we kind of alluded to in the Keynote 054 discussion, that will probably be a difficult thing to read out. Nevertheless, this study had a primary endpoint of recurrence-free survival, and they presented us with a couple of these. We saw an interim analysis 1, then we saw an interim analysis 2. The interim analysis 2 was published in Lancet in 2022, actual Lancet, not Lancet Oncology, but Lancet. And at the at the interim analysis 2, the pembrolizumab had a recurrence-free survival of 86%, the placebo arm 77%. So there's about a 9% absolute benefit there. Medians have not been reached. And then we just saw in 2024, January, in JCO, a report of the distant metastasis-free survival. So the final distant metastasis-free survival and the intention to treat in all the subgroups. And there seems to be a benefit there in that population, in those populations for DMFS, which maybe leads me to a question, James. People are now talking about DMFS in addition to RFS. Back in the interferon days, the way it would get published is RFS kind of as the endpoint. DMFS was a subgroup of that, noting that, RFS includes your regional recurrences and your distant. DMFS is just your distant. And then there would be an overall survival curve. There seems to be a narrative these days that DMFS is really our most relevant endpoint for adjuvant trials because it portends metastatic disease. I'm not sure if I'm fully on that bandwagon because regional disease still does occur. You can salvage these patients with surgery. I think that's an important endpoint. What is your feeling on DMFS and how we should be interpreting it?
I think the short answer would be not over-interpreting it. I think I'm on the same page as you, really. I mean, things I worry about would be if RFS and DMFS weren't concordant. I mean, if they're concordant, I think, great, makes sense. And the point about local recurrence, I think, is pretty well taken as well, because actually, if you have a local recurrence despite adjuvant anti-PD-1 therapy, you could say, okay, maybe that's not so bad. I would argue actually it probably is bad. Because they're refractory to our most potent treatment. So those kinds of patients are going to be at really high risk, actually, of dying of melanoma subsequently, even if they don't have metastatic disease then. So, I'm sort of fairly relaxed. I think it's difficult to make a strong argument that one's kind of quote unquote better than the other one. So just to maybe ask a couple of questions about the trial. Do you think there was much to say about toxicity that we didn't know already? A year of anti-PD-1 versus placebo, any differences?
That's a good question. I mean, nothing jumps out at me, not for my eyes. What about you?
No, I don't. I mean, I don't think so either. I guess that was really for the benefit of completeness. And then what about hazard ratios in different subgroups and how to say 2B versus 2C? And then, as a sort of null hypothesis, if you like, just to make everything easy, does this look quite like stage 3 in terms of hazard ratios, in terms of risk reduction? And so then it's just a question, as we talked about before in clinic, of sitting with the patient, sort of talking about where they are on those curves, what they stand to gain from treatment. And because that's the way I think about it, right? I think about biologically, they're different entities, but they're not completely different entities. And actually, there's a fair amount of overlap, I think, between stage 2 and stage 3.
Yeah, you said something I also wanted to just tie into. Local regional recurrence is concerning if it happens after exposure to PD-1 while exposed to PD-1. And, if you're a patient, that's just as devastating to you as a distant metastasis. Either way, I think you think this melanoma is behind you and all of a sudden it's served up in front of you again, whether that's local, regional, or distant. The hazard ratio hovers in the 0.6 range for pembrolizumab over placebo for stage 2. So to me, that feels like it's in the right ballpark for stage 3. We often think of a halving of the risk when you take active therapy versus placebo. It's a little more nuanced than that if you go through some of the supplemental data because just of these subgroups that we're talking about. So I think a 0.6, 0.7 hazard ratio in these adjuvant trials is about what we're seeing with these modern therapies. Let me know if you feel differently. With the interferons and ipilimumabs, it was not quite as generous as that. So this gets into that number needed to treat discussion, which is, it's a very academic conversation. That's not a conversation that most patients can tie into. So ultimately, you're talking to a patient now with stage 2 disease that has somewhere between a 20% and maybe as high as a 40-50% risk of recurrence in these first few years. And you're trying to lower that by a portion, maybe not all the way down by half, but down to a portion. So taking a 20% risk down to 12, 14%, taking a 50% risk down to some 20%, or not 20%, sorry, to 35%. Ultimately, it's a conversation of, are we hitting, you said it nicely, are we in the sweet spot where they are in danger of recurring and this therapy may actually be beneficial for them? But 716 will be interesting because as those patients on placebo recur, and if they get PD-1 at recurrence, if we can make any heads or tails out of that, what will actually happen in that cohort is many people will come off and get combination therapy at their first recurrence. That's the group I'm really interested in. So did you need adjuvant PD-1, or could you just allow a stage 2 patient to declare themselves, and at declaration is combination as their first touch the most effective therapy? What do you think?
Yeah, I mean, I don't disagree with any of that. I mean, my nervousness about watching people at significant risk of relapse is a devastating presentation of metastatic disease, as the first presentation, brain mets in particular.
How often do you think that actually happens?
Not that often these days. I mean, I think in the old days, we used to see a fair amount of it, but you do occasionally see it. And, when you had a treatment that you could have given them, you think, oh, well, that may have helped stop that. I mean, obviously, this is all navel-gazing, to say the least. But, that kind of worries me a little bit, I have to say. The other thing I was actually just going to maybe talk about a bit as a stage 1, you mentioned it kind of in passing, but it's actually really interesting. A lot of people talk about this whole idea that actually of the people who are relapsing with metastatic disease, if you do the maths, or math, as you would say, a lot of them will have had stage 1 to start with, or not stage 2 or stage 3. So they may not ever have even
what do they call it? The paradox?
May never have come to our clinic. And the first thing we know about it is someone who presents usually symptomatic in the emergency department. And those patients are very, very difficult to treat by definition for all the obvious reasons. So, I mean, I suppose my thought on this is that on, in terms of trying to think about adjuvant treatment in that group of patients, it's close to impossible with the tools at our disposal today. You really need to have really accurate biomarkers for really picking out the bad early stage melanomas. And there's a fair amount of work there, but to me, at least, I haven't seen anything that looks like it's close to kind of prime time, as they would say. But what do you think?
Well, so that's right. I've heard this paradox a lot of times. If you look at who's diagnosed with melanoma, what stage are they at diagnosis? Very few are stage 4 at diagnosis. Majority of our patients are stage 1 and 2. I think that accounts for what's the number I've heard? Maybe 2/3, half to 2/3 are stage 1 and 2, a third are stage 3. And then, 10, 15% are stage 4 at diagnosis. And the trick, I mean, this is something Jeff Gershenwald, who, is one of our gurus for AJCC staging, he really makes this point that I think is lost on the way we kind of colloquially talk about patients. You're staged once and only once as a cancer patient. You're staged at the time you're diagnosed. So if you are a stage 1 melanoma patient, and then 6 years later, you end up at the Marsden in your clinic with symptomatic disease, you're not stage 4, you're stage 1 now with metastatic disease. And so, in a clinical trial demographic table, we say we're enrolling stage 4 patients, blah, blah, blah. But what we really want is we want metastatic melanoma, regardless of what stage they were at diagnosis. And that's just a semantic thing, but it's kind of important in cancer registries as it goes, because we really should stage these patients only once. So that being said, majority of patients are staged as 1 and 2, but the majority of our deaths from metastatic disease come from that pool of patients, because those are the ones who over time go on to develop metastatic disease. And so that is, I mean, I agree with you. We don't have a great biomarker. I would love to see some sort of imaging or blood-based biomarker. You'd love to see something that could actually see that there's residual melanoma inside the body. But I also think we should be careful with over-treatment, because we're going to then, we're going to be over-treating, without really knowing who's at risk. And the flip side is also difficult. The patients that I really cringe counseling the most are those stage 1 patients, because I want to be able to say these numbers, 95 to 97% chance you're surgically cured. But in the back of my head, that tells me 2 to 5% of you guys are not. And I can't pick you out in clinic. I really don't know who's who. I have some ideas, but I don't know. And so that's difficult, because you don't want to say that. And then, when the person recurs, you don't know who it is. The reason I asked you how many times people present with that kind of catastrophic CNS, spinal cord, brain mets is there are some trials being designed for that space. And I think it's a tricky space. We have one in SWOG called S2000, and it is for untreated metastatic disease that involves the CNS that has never seen treatment before. So that means somebody has made it through primary definitive treatment, surgery historically, and we had to amend it to allow PD-1 therapy and then a gap of more than six months adjuvant therapy. So somebody's made it through that therapy, and then their first presentation site includes the CNS. And I just find that to be, a challenging group of patients to find out there. They do exist, but the more common scenario is that you're metastatic, there's some therapy applied, and then that treatment, is refractory, or the cancer is refractory to that treatment, and it spreads to the brain, rather than you have the asymptomatic. Anyway, that's why I was asking that question. Nevertheless, I agree with you. That's a heartbreaking presentation.
Yeah, no, that's interesting though. So what's the intervention in that trial, Ipi-Nivo?
It's a trial of Ipi-Nivo versus BRAF MEK PD-1. So encorafenib,
Triple.
binimetinib, and PD-1. And some of this was based off of that Tricatel study that I know you're intimately familiar with. We'll talk about in a future podcast, I'm sure. So doublet versus a triplet, but not triplet in the way we normally. I mean, we have to be careful when we say triplet, because I think there's various forms of triplet out there. So I always think it's important when somebody says triple that they explain this triple is BRAF MEK PD-1. That's the classic triple we've been using. But you could think of a triple being, we saw something called the TACO trial at ESMO last year, which was bevacizumab, atezolizumab with a MEK inhibitor, so that's a triple. There's triple checkpoint blockade coming. So I think there's, we got to be careful when we say triple, what that means.
Yeah, I mean, I was just going to say we're probably running out of time, but my comment about that trial design, I may have said this to you before, is it's a nice idea, but I would really worry if the people who are getting the Ipi-Nivo do not get to BRAF targeted therapy, which is I'm slightly riffing off DreamSeq there, if you see what I mean.
Yeah.
Because for me that's just a disaster in clinic if you've got someone, you're treating them with Ipi-Nivo up front for bad, high tempo symptomatic disease, particularly in the brain. You have to watch them really, really, really carefully. This isn't a patient you just say, we're going to see you in 3 months. And if you're worried they're progressing clinically, I think most relevantly, actually, I mean, do scans and stuff as well. They need to have BRAF targeted therapy for salvage at any time. And so I'll be interested to see that when the trial reads out, because I'll be standing up and criticising if there are patients who've died without getting targeted therapy in that arm.
And that was sort of my point when the study was being operationalized. I was really concerned about the no prior therapy, because aren't we then sort of selecting for people? If it's going to the brain first, aren't we sort of selecting for patients with a tempo that gives us pause, that you might want to slow down first with some targeted therapy? But we can put a pin in that discussion. Actually, let us circle to BRAF therapy for a second, because we're talking about stage 2 here. So in stage 2, there is no BRAF targeted therapy option in the adjuvant setting. There's not even a trial available for those patients, to my knowledge, right now around the world. So what is the status of testing a stage 2 patient for BRAF in the UK right now?
Yeah, I mean, I'll answer that in a sec, but I'll just make a quick observation about BRAF mutant stage 2. It's a shame we don't really have any good quality data at the moment. Do I think BRAF targeted therapy would have benefit in that situation? Yes, I do. That's my own speculation. And just one quick footnote, and is that I think the BRIM-8 adjuvant trial, so that was vemurafenib single agent back in the day. It's a story in its own right, but I won't dwell on that too much. Mainly stage 3, but actually there were a few patients with stage 2 in that trial, just a handful, 10 or 20 or something like that. And I'm not sure the extent to which it came out in the publication, and if it did, I think it would have been in supplementary. But I remember seeing quite early on, maybe at a meeting or something else, the curve actually for those high risk stage 2s. And do you know what? I don't know if you've ever seen this. It was flat. No one had recurred, basically.
Interesting.
Yeah. So vemurafenib single agent. I mean, that's probably now a historical footnote, and maybe we'll need to do a correction on this and look it up properly. But I'm not really sure that kind of message has ever come out. Right. So reimbursement for let's call it mutational analysis, because we tend to do panels now. Basically, if we're doing mutation, I mean, BRAF's kind of really the only thing that's actionable at the moment. There's no reimbursement issue there for us, basically. So we've always tended to take a view that anyone who is potentially at significant risk of relapse, so that could be stage 2, stage 3, etc., we do BRAF testing. It's just part of the initial workup, basically, because part of that is it's a relatively straightforward thing to do, actually. And then the other thing is that, I, in the early days, was burned quite a lot by people turning up in clinic in extremis and not knowing if there was a BRAF mutation or not, which slightly speaks to some of what we were saying before, a really bad, rapid relapse. And then, we've treated people empirically with BRAF targeted therapy in the past when they were literally just about to, which is obviously not without risk for all sorts of different reasons, but we've just had to do that because they were going to die otherwise. So, as ever for me anyway, I've just been burned a lot clinically. But in the US, you have reimbursement issues with this, right? That's the point. Yeah.
But potentially, yeah. In stage 2, you potentially would. Now, is insurance looking so carefully that they can tell that this was a stage 2 and not a stage 3 that you're testing on? But, because you don't have a therapy, there's no urgency, except for the point you made. Now, that gets me to 2 questions. One is, or let me make 1 point and 1 question. The point being, although I would love to empirically give BRAF when you're in crisis or extremis, as you say, to a patient, the issue will always be that as you try to prescribe it, you'll get something called a prior authorization form back that says, show me proof of the BRAF mutation. So in absentia, you won't be able to get that dispensed. Now, the question for you is, for us, BRAF testing can take upwards of 7 working days, which really turns into 14, real life days, because it has to go to the warehouse. The request is received for a full day, then warehouse 2 days to go retrieve the sample, then 2 days on the pathologist desk to circle the tumor tissue, then extraction, sequencing, reading. So all of this really feels like it takes 2 weeks or longer. I've had patients come back 3 weeks after the request and we don't have the result. And then you have immunohistochemistry for the mutated protein, which still has the tissue retrieval issues, the request, the warehouse, the pathologist desk. The stain, however, is essentially a 24-hour stain as opposed to DNA extraction sequencing, which can take 72 hours. Are you guys using more immunohistochemistry, or is it full DNA sequencing, or it just is case by case?
Mostly sequencing is the short answer to that. I mean, interestingly enough, it seems to take us longer, I shouldn't be speaking out of turn here, to get BRAF results now than it maybe did 10 years ago, because we used to get them very quickly, within 2 or 3 days. And it seems to be, and maybe that's an issue that in lots of different types of cancer now, lung cancer is a good example, there's a load more mutational testing going on. So there's probably in the lab, in the early days, this might have been one of the only things they were doing, but now there's loads of different ones. In any case, in situations where you really need a quick result, though, and you don't want to wait for a few days, we do the immunohistochemistry. It's fine. I mean, it's not as good. Right. Honestly, I don't really like it. I want to see the mutational analysis, and actually, I want to know what the BRAF mutation is as well, because again, there isn't time now but there's a bit of a story out there, isn't there, about different, non-V600E BRAF mutations. What does that mean? Are they targetable? Can we get the drugs? What's the efficacy? All that sort of stuff. But yeah, so that was quite a long answer, I guess. So we should probably wrap up on this because it's meant to be about Keynote 716, wasn't it? So what's the take homes?
Take home is this was the first immune checkpoint inhibitor noted to have significant benefit in stage 2B, 2C, completely resected, meaning you looked at the lymph nodes and removed it. With a point, maybe we missed the opportunity to talk about this point. If you don't go looking at the lymph nodes and you assume somebody is clinical stage 2B, 2C, without looking at the lymph nodes, that hazard ratio benefit is not the same. It cannot be the same if you actually have subclinical stage 3s that you're treating. So that 0.59, 0.6 benefit that you see in 2B, 2C, DMFS, and RFS, this is really only if you know for sure that they're lymph node negative. So benefit in RFS, DMFS, OS to be determined. And it received approval, now almost a couple of years ago in the US, and, continues to generate some interesting questions. So that's the take home. Hi, everybody. We're doing a quick fact check on episode 8. This is Keynote 716. James, I think the real fact of the episode is something you made. You made a comment about BRIM-8, the BRIM-8 study, because obviously Keynote 716 is for treating stage 2, and you just made an observation about a figure in BRIM-8 and a subgroup there.
Yeah, and it was sort of almost an off-the-cuff type of comment, but just to track down the reference there. So the publications in the Lancet Oncology, April 2018, Michele Mayo is the lead author and Dirk Schardendorf is the senior author. And so without dwelling on this too much, this is basically adjuvant vemurafenib single agent. But the median follow-up for this study at this report was 33.5 months, so just to say that. And then this study actually enrolled a small number of participants with stage 2C disease, just a handful, the bulk of those in the study having stage 3 disease. And so then the question really is about what did we see in this really small group of people with 2C disease. So then if you go down and you look at the figure 3, which is DFS, and then we look at part B of the panel. This is a forest plot, and then focus on stage 2C. So first of all, really small number of patients, so 27 in total, 12 in the placebo arm, 15 in the vemurafenib group. But at the time the study was reported, 6 of 12 in the placebo group had an event, and 0 of 15 in the vemurafenib group had an event. So those are the facts. The questions are going to be what that means, duration of follow-up, really tiny numbers. But I think it's an interesting observation.
Yeah, I mean, what I see from that is something, it's confirmation of a hunch, and I like that you brought this back in our memories. It's this idea that BRAF inhibition in the adjuvant setting might be eliminating clones that left untreated or so small in microscopic amounts may not trigger an activated immune response in response to anti-PD-1 therapy, but targeted therapy can find that mutated protein in microscopic quantities and eliminate those subdominant clones, if you will, or just undetectable clones, to the point that it actually could, at this median follow-up of nearly 2.5, 3 years, shows no recurrences in that treated arm versus 50% recurrence in the placebo. Small numbers, like you said, but it's a signal that sort of seems to confirm something we feel, and maybe, allows us some comfort in the adjuvant setting to explain why we might choose BRAF/MEK over PD-1 in certain situations.
Yeah, and I suppose just for the record, this study overall was basically negative.
Yeah.
Didn't lead to a label for single agent vemurafenib in the adjuvant setting, but nonetheless, interesting observation. So we're good.
Yeah. Yes, I don't want to say more about it, but if we need to record again, we certainly can. The only other thing I was going to say is I made some silly comments at the beginning about when Ann Richards was governor of Texas, and maybe it was worth just like putting a timeline on that. So she was governor of Texas in the 1990s, 91 to 95. These were my formative high school years, if you will. And then that comment about my mom winning the first Texas Lotto. And I had this real memory that it was November because we had a nice Christmas. And fortunately, my memory holds. It was the very first Texas Lotto is November 7th, 1992. Not a scratch off, but where the numbers get allocated. So that was all right. So yeah. So anyway. All right. That's it then. Thanks for this fact check.
Okay.